pleasure to be here and take on this somewhat challenging talk. And you can see I subtitle it, Are the Murky Waters of this whole thing any clearer at this point in 2012? So let's work our way through this a little bit. Goals for therapy of esophageal cancer, pretty straightforward. Local control, cure the disease, and allow comfortable alimentation afterwards. That's something we as surgeons can do quite effectively. Where we have problems, though, is eradicating systemic disease. That's not something that surgery is generally able to accomplish. So that led into the concept of additional therapy, and you can add the therapy at the end of resection, or more commonly, we use it as neoadjuvant therapy before resection, or you can eliminate resection altogether and give the therapy as definitive therapy. And we're going to focus today on neoadjuvant therapy followed by resection. So these are the issues that I'd like to take up and discuss. 5 things that I think are particularly important and we can try to get our arms around a little bit in this 20-minute session today. So first, who should get neoadjuvant therapy? Should it be selective or should everybody get it? Secondly, does it help? And if it does help, who does it help? Third, which one should we be using, chemotherapy or chemoradiotherapy? And how much of what we're using should we use? Fourth, is resection still important after neoadjuvant therapy? And if you are going to resect, does the type of resection matter? And then lastly, what do we know about staging, prognosis, and recurrence after the use of neoadjuvant therapy? So let's start with who should get it, selectively or everyone. It wasn't long ago, probably within the last decade, that the concept was out there that esophageal cancer is systemic at the time of diagnosis. So pretty much everybody with esophageal cancer has systemic disease. Hopefully, nobody in this room still believes that to be true. If so, then this will convince you of otherwise. This is surgically treated patients, only surgery, and essentially 100% survival with intramucosal cancer. So this is a group of patients with esophageal cancer who clearly don't have systemic disease. And in fact, we now know that we don't even need to resect these patients. This is a series that we published recently of endoscopic therapy for intramucosal cancers. And these patients just had endoscopic ablation or endoscopic mucosal resection and are cured from their disease. Clearly, they don't have systemic disease. Well, if they don't have systemic disease, is there a downside to giving everybody chemotherapy? And that question, Tom Rice gave us some early insights on back in 2003. He looked at clinical T1 and T2 tumors and compared what he usually experienced after resection with what he was finding when these patients had neoadjuvant therapy. And what he showed is that there is a downside to giving everybody neoadjuvant therapy. Compared to what he expected the survival to be from his historical controls for surgery alone in this subgroup, the observed survival was inferior after the neoadjuvant therapy. And this finding has been borne out in a recent randomized prospective trial. It's only published in abstract at this point, but in early stage tumors, the outcome was worse with neoadjuvant therapy than the surgery alone arm. So who should get the neoadjuvant therapy? I think if we step back and look at the rationale and the goals for neoadjuvant therapy, that'll help us a little bit. What we'd like to do is improve the R0 resection rate or shrink the tumor so we can get a better resection on it, reduce local regional recurrence, and reduce systemic recurrence. So clearly in these early lesions, we don't need to shrink them. They're small, we can take them out with primary surgery. Again, local regional recurrence for a small lesion, not a big deal. So we're focusing in on local regionally advanced tumors and then those where there's a significant risk of systemic recurrence. So these we can sort of pick out with our endoscopic view or endoscopic ultrasound. Is there something that can help us identify the patients at risk for systemic recurrence? And indeed, I think we can now use some things to look at that, and that's lymph node disease. This study was put together by a group of us, about 6 or 8 international centers, and when we put our data together to come up with this slide. It's about 2,000 patients treated with primary surgical resection for esophageal cancer. And what you'll see is this is the curve of systemic recurrence based on the number of lymph nodes. And the important thing here is that you cross the 50% line when you go between N1 and N2 disease. So that's 3 lymph nodes. So less than 3 lymph nodes, 2 or 1 lymph node, less than 50% chance of systemic disease. As soon as you get 3 or more, become N2, the risk exceeds 50%. So if you're going to give chemotherapy for a risk of systemic disease, it makes sense to give it to the group that have crossed the 50% mark. Once you have N3 disease up in here, essentially everybody will get systemic disease unless treated. So now we have a way to pick out those patients at higher risk for systemic disease and target them for neoadjuvant therapy. So the answer to the first question, who should get it? Patients with locally, regionally advanced disease and those with N2 or greater lymph node disease. All right, let's take on the second question. Does it help? And if so, who does it help? This was the first positive trial that was published in the literature, the infamous Welsh trial published in New England Journal of Medicine in 1996, showing an improvement in survival with the use of chemoradiotherapy over surgery alone. There were a lot of problems with that trial. The staging was horrible in the patients, and as you'll notice, it's probably the worst surgical survival ever published. Besides that, the problems go deeper. If you read the text of the paper, this is the median and 1, 2, and 3 year survivals published in the manuscript, and they fit the surgical survival curve perfectly. In contrast, if you plot the data for the neoadjuvant arm, it does not fit the curves. In fact, it's way off of the curve. If you plot that out and run the statistics, I doubt it would be statistically significant. We asked the New England Journal to do so, and they refused. And there's a published erratum that you can read, but the result is that we still, to this day, don't know if that trial is really accurate, and it likely is not. Well, this then was the second trial that was positive. This is the English Medical Research Council using neoadjuvant chemotherapy alone compared to surgery. There were a lot of problems with that trial as well. One of which is the, again, abysmal surgery and the poor staging. The end result was that 19% of patients had no resection, 22% of patients left the operating room with gross tumor in the body, and a full third of patients had microscopically positive tumor margins. So pretty abysmal surgery. Nonetheless, they demonstrated improved survival with that poor surgery by the addition of chemotherapy. And then we have the MAGIC trial, the most recently published positive trial. The problem with the MAGIC trial is largely a gastric cancer trial. It was expanded to include GE junction and distal esophageal adenocarcinomas because of poor accrual for the gastric cancers. As a consequence, there's only about 70 adenocarcinomas of the esophagus and GE junction amongst the 500 patients that were included in this trial. Nonetheless, they did demonstrate again an improvement in survival with the use of neoadjuvant chemotherapy. What's interesting is that if you look carefully at that MAGIC trial, you'll have to do the numbers and calculations for yourself because it's not anywhere in the manuscript. What they demonstrate for the first time, really, in esophageal cancer is a reduction in systemic failure. If you read the manuscript, find the numbers, do your own chi-square analysis, you'll see that the systemic recurrence rate is reduced between the surgery and the chemotherapy arm. They also showed a reduction in local regional recurrence, but we know that's been demonstrated before. But this is the first demonstration of a reduced systemic failure rate. Curiously, though, why would they not discuss that or even do that math in the manuscript for you? If it's such a critical finding, why is it nowhere in the manuscript? Again, questionable what's going on there. So we have 3 major positive trials. The Walsh trial suffers from the poor staging, horrible surgical survival, and the incorrect statistics and graphs. The MRC trial, again, poor staging and poor surgery with very low R0 resection rates. And the MAGIC trial, which was largely a gastric cancer study, and then this issue of why they didn't talk about the systemic recurrence, which is a huge finding. So this is not exactly a solid foundation for the use of neoadjuvant therapy, despite the fact that it's nearly standard of care. Well, this is a recently published meta-analysis of all the different trials that have been done. This is for the chemoradiotherapy, and you can see the list of trials here. And you also notice that the majority of these are done for squamous cancer or a mixture of squamous and adeno. Very few are done for adenocarcinoma alone, which is the disease that we treat 90 or 95% of the time in the United States of America. If you break down in this meta-analysis the survival for the surgery alone versus the chemotherapy versus surgery alone arm, particularly in the squamous cell cancers, there seems to be a suggestion that you get an improvement in survival with the use of chemoradiotherapy plus surgery for squamous cell. Suggested also for adenocarcinoma, but again, if you took out this Walsh trial, suddenly there is no significance. Neither of these trials was positive, so the significance would go away if you took out the Walsh trial, and we talked about that issue. These are the trials that lump squamous and adenocarcinoma together, including the Tepper trial, which again was largely a squamous trial, closed early, so a small number of patients, but largely a squamous cell trial. And the issue of mixing squamous and adenocarcinomas together was nicely brought out in this randomized trial by Burmeister. They actually broke down their analysis within their trial by squamous versus adenocarcinoma. And you'll notice it was the squamous group that got the benefit, not the adenocarcinomas. So mixing those two together may give us misleading information in these randomized trials. This is the list of neoadjuvant versus surgery for chemotherapy alone. The trials listed here, and mostly again squamous cell and some adenocarcinoma. You'll see that the MAGIC trial is missing. This group chose to omit the MAGIC trial, considering it essentially a gastric cancer trial, and so they excluded it from their meta-analysis of the esophageal and G-junction adenocarcinoma trials. And this is what they found: less impressive results for squamous cancer with the use of just chemotherapy followed by surgery. And again, a suggestion of some benefit, perhaps, with chemotherapy for adenocarcinoma based largely on this recently done French trial. Well, who benefits from neoadjuvant therapy? The group that is most in need of benefit are those with the most advanced disease. And there's some information that perhaps that group does not get as much benefit as we would like them to get. There's two studies that are available that looked at pathologic staging of patients prior to beginning the neoadjuvant therapy. Kresna looked at minimally invasive staging and noticed that the complete pathologic response rates were much lower than what you would expect or read about in trials where there was no pathologic confirmation of nodal disease. And this was confirmed by Wallace, who did endoscopic or EUS FNA to document N1 disease, and again came up with about the same number. 14% pathologic complete response with neoadjuvant chemoradiotherapy, and I'll show you some data in a little bit, but we would expect these to be up in the 20 or 25% range for complete pathologic response with chemoradiotherapy. So suggesting that if you actually prove that they have N1 disease, the group that really needs to get a benefit, the benefit may not be as much as what we would like. And this graph also from Tom Rice points to the issue that we're dealing with. So if you have early stage lesions or non-responders, there's a cost to neoadjuvant therapy. You're probably losing survival. This is the group we really want to work on, the group that could potentially benefit, and these are the patients that have local regionally advanced disease or are responding well to the therapy. So how can we isolate this group and minimize that group is an important issue. And one of the things that everybody should be aware of is this Municon trial, where they were looking at PET to predict response. So what they did was there's no radiation, it's just a chemotherapy trial. They would start the chemotherapy and repeat the PET at 2 weeks of therapy. If there was an SUV decrease by about 35%, they considered those patients to have a response, and they continued on with additional chemotherapy. The non-responders, at this point, they just continued on to see what would happen to them. Now they're switching those to different forms of therapy to try to improve the outcome in the non-responders. And this is what they showed. Compared to the non-responders, significantly improved event-free and overall survival in the responders. So not a big surprise. If you're responding, you're going to do better than a non-responder. And again, the goal is to pick out better and better who these responders are so we can focus the therapy on the responders and minimize the cost to the patients that aren't responding. So who benefits? PET response, it's not useful, unfortunately, if you're using chemoradiotherapy, and that's been demonstrated in several trials now. And it remains unclear, even with just chemotherapy, the Municon approach, if that is workable, because others have tried and been unable to fully replicate the results that they achieved in Munich. So we really need predictors of response pre-therapy, such as gene expression, or some type of guided therapy so that our therapy will actually work in the patients that we're giving it to. What defines benefit is another open issue. Is it survival overall? Is it pathologic complete response? Is it a major response to the therapy, minimal residual disease, or is it a node-negative patient? Those are all sort of open questions yet. And does it differ between chemo only and chemoradiotherapy when we're talking about response? We know those responses are going to be different, but what is the end point that we're looking for when we're using chemotherapy or chemoradiotherapy? No question, though, it's had an impact in the United States. This was just published recently, looking at the use of neoadjuvant therapy in the United States. Fortunately, and we see a good thing here, for stage 1 tumors, it's going down, so people are recognizing there's no benefit in the early tumors, and we're seeing the majority of patients with more advanced tumors getting neoadjuvant therapy. So, second question, does it help? Probably in some patients. It may be less effective in those patients that really need it, though. Now, which one, chemotherapy or chemoradiotherapy, and how much? There's no question there's a difference in pathologic complete response rates. And if you look at all the randomized trials, the pathologic complete response rates with chemotherapy run around 4.5% or 5% versus somewhere around 20% with chemoradiotherapy. And this is the trial, this is the results, long-term results from Mark Oringer, showing that in his experience anyway, it's really the patients that have a complete pathologic response that get the benefit. Anybody with residual disease actually did worse than the overall group. We've tried to look at this a little bit, and this is grouped data, again, from multiple institutions around the world. And we put this together. Unfortunately, we found there was a significantly higher stage in the chemoradiotherapy group, which sort of negates the findings. But the findings suggested chemotherapy seemed to do a little better, but again, the staging probably makes that invalid. DeMeester actually compared this in a randomized phase 2 trial, 2 cycles of chemotherapy and then 35 gray, relatively low dose of radiotherapy. They found a complete pathologic response rate of 13% in the chemoradiotherapy arm, again, lower than you'd expect, probably related to the low dose of radiation, versus 0 in the chemotherapy alone arm. The R0 resection rate was higher with chemoradiotherapy, but there was no difference in survival between chemotherapy and chemoradiotherapy in that trial, and there's the curve. And this meta-analysis compared what data was available and came to the conclusion probably a slight benefit for chemoradiotherapy versus chemotherapy. So the question of how much radiation, this is from MD Anderson. They looked at local regional control rates and disease-free survival with greater than 51 or less than 51 gray of radiation and demonstrated that you had improvement when you got up around or over 51 gray. But what they also showed is that the curve flattens out quite dramatically. Once you get to about 45 or so, there's not a huge change in the curve. So you definitely want to get to about 45. You're not gaining a whole lot of ground. And when you get out here, you're gaining a lot in terms of morbidity with that high-dose radiation. Well, what about chemotherapy? Do we have any information on how much chemotherapy we should be giving? This is an interesting trial. It came out of the same group that did the Municon trial. So they started with a plan for 3 cycles of chemotherapy, but 30 patients were unable to continue beyond the first dose because of toxicity. So they went back and looked at the outcome in the patients that only got the 1 dose versus those that completed the whole series of 3 cycles. And what they found was that at the end of the day, it did not seem to make a difference in survival whether you got 1 or all 3 doses. What was critical was, again, whether you responded. If you had 1 dose and responded, you were better off than guys that got 3 doses and didn't respond. So again, response is a critical issue when we're talking about neoadjuvant therapy. So the answer to the question, which one and how much, it appears to be chemoradiotherapy is favored, and you want to limit your radiation probably to 45 or 50 gray. Now, what about, is resection important after neoadjuvant therapy, and does resection type matter? One of the issues is, can we identify patients that have had pathologic complete response? And the answer to that question is unfortunately no. PET-CT has an accuracy only about 56%, and endoscopic ultrasound is about the same at about 50%. The pathologic complete response rates that we've talked about are 5 to 25%, so it's logical that these patients should have a resection. Again, from MD Anderson, showing the benefit of adding resection to neoadjuvant therapy. This was published back in 2004, and you can see the curves here that are benefiting the addition of resection to just the neoadjuvant therapy. And a French trial went on to look at this. It was published back in 2007, so they randomized patients with squamous cancer. It's important to remember that the majority of these had squamous cancer, very high dose radiation, 66 gray, and what they demonstrated was there was no difference in survival when they used high dose radiation, but again, this isn't squamous cancer and may not be valid for adenocarcinoma. But one thing we know is that the local regional recurrence rates are higher with a transhiatal resection than an en bloc resection. And these are pooled data from a number of studies showing the differences in the local regional recurrence rates based on type of resection. But the issue is, does it matter after neoadjuvant therapy? This is Oringer's study showing a significant reduction in local regional recurrence rates using transhiatal resection with the addition of neoadjuvant therapy. So do we still need to do an extended resection after neoadjuvant therapy? One thing is for sure, and these are the Kelsen trial and the long-term follow-up of the MRC trial, what is important, whether you've had neoadjuvant therapy or not, is getting an R0 resection. The patients that had the best survival in these randomized trials were those with an R0 resection. So no matter what, you need to get a good R0 resection or the survival is abysmal. So we asked ourselves that question, does it really matter? And this is a paper we published a few years ago looking at a relatively small series of patients that had either an en bloc or a transhiatal resection. This was overall survival, favoring the group that had an en bloc resection. If we limit it to those patients just with residual disease, you can see the survival was significantly advantaged in the patients that had an en bloc resection. And in fact, if we looked at absolute survival, so not calculated, but absolute survival, 35% of patients with residual disease were alive at 5 years after an en bloc resection. Nobody was alive at 5 years after a transhiatal resection. So the answer then to the fourth question, is resection important? Yes. Does resection type matter? Yes.
Let's hold the last part for the discussion.
Sure. Okay.
Thank you very much.
After